Hello and welcome to the GAP MASLD MASH Community Network meeting with Millie N. My name is Trisha and I'll be your moderator today. I'm joined here virtually by our presenter, Millie N. Um, there will be an opportunity to ask questions live at the end of the presentation and network with the other participants. Now I will pass things off to Millie.
Hi, welcome to the Get Muscle Mesh Community Network. My name is Millie Ng. We will talk about lifestyle management today. I work in Tufts Medical Center as a hepatology nurse practitioner in Boston. So, as introduced, thank you for Trisha for giving us this chance. And here's the QR code if you haven't registered for the meeting. If we haven't done this, so we can do it at the end of the meeting. But I will be very curious to know who's in the Zoom. Are you all hepatology, GI, APP? I would assume so. And this presentation is tailored for providers who take care of fatty liver patients. If you are working in the primary care setting, this presentation is also a very valuable asset to take care of these patients with metabolic syndromes. Here is a QR code to visit the Get Muscle Mesh Community Network to view Madrigal Mesh Disease State Education and Madrigal OSD for promotional program. So now we will back to something here. Okay, so let's return now to our patient Albert. Albert is the patient we see in the clinic, 65 years old man with BMI 29. We call that obesity. Is referred to you for elevated liver enzyme with abdominal imaging showing steatosis. Let's look at some of his labs. He has this triglyceride of 89, good cholesterol 41, A1C 7.2, ALT with no elevation for about 3 years, 1 to 2 times upper limit of normal. And he has done this chronic liver disease workup, which has been negative. He has no alcohol since his 20s. His metabolic syndromes include type 2 diabetes, hyperpressure, and high cholesterol. The key exam is he doesn't have other advanced liver disease. His BMI is 29. This is a typical patient that we see in the clinic. So the diagnosis is MASLD, in lung metabolic dysfunction associated steatotic liver disease. So as discussed previously, clinical decision tools have been updated to help guide the application of non-invasive testing. So we will apply the MASLD AGA clinical pathway flowchart to the cases presented today. Here you go. So for Albert, we know he's at risk for MASLD and MASH, given his metabolic risk factor and his steatosis on imaging. So we first calculate his FIB-4 score using ALT, AST, platelet count, and his age. And we calculate his FIB-4 is 2.22, which indicate an indeterminate risk. So what should we do next? So we subsequently complete a fibroscan, which is a non-invasive testing with a so for his result is 6.7 kPa, which indicates low risk for liver stiffness. So he is low risk for significant fibrosis. So he's not indicated for liver targeted medication or not GLP at his case. So the prescription for him is lifestyle modification, including maximizing the metabolic disease management, and we will repeat the non-invasive testing assessment in about 1 to 2 years. So here's all the, so we will have about 20 slides today. This is about 1/3 of it. We're going to put in some fatty liver education model, and then we'll go back to the case later. I would say this is a story of fatty liver. So if you have a patient comes in with BMI typically over 30, has obesity, or they have type 2 diabetes, or 2 or more metabolic dysregulations, including sleep apnea, hypertension, hyperlipidemia. Plus, our main character today, fatty liver. So if you can follow the arrow, fatty liver steatosis, as time goes by and there's nothing changed in terms of lifestyle, the fat in the liver can cause inflammation. And at that stage, we call it steatohepatitis. If we leave it untouched for a longer period of time, it can develop scarring of the liver. And we name it as fibrosis in our liver world. So a lot of fibrosis can cause cirrhosis. And cirrhosis this is the biggest drive to develop into hepatocellular carcinoma. And indeed, with fat in the liver can also promote the development of liver cancer. One thing that is reassurance in this picture is if you look at the blue arrow, as long as you get fatty liver, you do something and don't allow it to develop into cirrhosis. At the first 3 stage, it is reversible. And that's why you are important to help the patient to reverse the inflammation of the liver by lifestyle modification. This is also some background about fatty liver. There are risk factors and pathogenesis that we will introduce in this slide. Basically, we are composed of 2 elements. One is genetics, the other one is environmental. So the genetics, which is a blue box, these are the interesting name of the genes that can promote fatty liver. Basically, they are promoting lipogenesis, decreased fatty acid oxidation, and it affects the signaling and the fatty generation. This blue box, we comes with it and we born with it. So there's nothing you can change too much about it. But let's look at the diet part, which is the environmental. This is something that we can change to reduce our risk to develop into fatty liver or steatosis or cirrhosis. So diet that promotes fatty liver are diets high in saturated fats, high in fructose, such as juice, such as soda, and high dietary fats, including a lot of omega-6, less in omega-3. So all these promotes fat in the liver. So some say current global obesity pandemic causes diabetes and steatotic liver disease. Even I can say with confidence that management of MASH must involve the control of diabetes and reduce body weight. How do we manage MASH? So it is always the math about input and output. The input is the nutritions that you obtain from your diet, and the output can be the energy you give out. So it's always better to have balance. If we have too much input, too less output, I think among all the possibility, it is the worst. So central obesity is the major promoter of insulin resistance and pro-inflammatory signaling. In the past, we might think, okay, someone is obese, you can get the fat deposition in the thigh, in the arm, in the abdomen. And some recent finding saying that it actually matters. The central obesity promotes the insulin resistance more than other people getting fat from depositing in other parts of the body. So back to our case. Albert actually asked, he has been eating a traditional Cuban diet consisting mostly of rice, beans, pork, corn, beef, plantains. So how can we best discuss this diet with our patients? And how do we tailor a dietary recommendations to cultural preference and food accessibility slash socioeconomic status? I think these are very great questions that we ask ourselves before we can tell the patient. Remember, he got this diagnosis of MASLD. So lifestyle modification is the mainstay of treatment. Whether the patient is indicated for medication or not, again, lifestyle modification, you cannot escape this. So that include dietary changes and exercise, with the primary goal being weight loss. Substantial improvement in histologic outcomes, including fibrosis, is directly correlated with increasing weight loss. So how much you want the patient to aim for the weight loss? So per book is about 5 to 10%. So sometimes I would engage the patient to ask him or her, hey, what's 10% means to you? They usually pause, and I feel like maybe more than half of the patient that I see cannot really calculate the 10% of their body weight, which is okay, but we need to bring their attention how much. So if Albert, we don't know his weight, but if his weight in the clinic today is 200 pounds, I will ask him, what's 10% of 200 pounds? That would be at 20 pounds. So 20 pounds come out from the patient's mouth. We make them aware of how much they should lose in terms of this number. So efficacy of diet and exercise treatment may be impacted by genetic polymorphism. So what is genetic polymorphism? Genetic polymorphism that influence MASH include whether someone is more susceptible to develop into MASH. Some people with 400 pounds, they never get a MASH. Some people with 114 pounds, they get severe fatty liver. So it is also the genetic makeup to tell a person whether they are easy to get MASH or not. Also, rate of progression can also come from genetics. Progress to fibrosis, progress to cirrhosis. And also, they have different response to specific treatment. When I prepared this slide, it is interesting to know that HIIT, namely high intensity interval training, is actually not that effective in MASH improvement, as a review study in 2023 show. And compared with the resistance training and the aerobic training, the resistance training is not superior than aerobic. It is because the energy needed to invest in resistance, meaning lifting weight, is less than in aerobic, such as you hop on your treadmill to run. So this is a good takeaway for ourselves as well. If you're here to improve MASH, between the weight and the treadmill, maybe it is better for you to choose the treadmill to improve MASH. So let's try to introduce a MASLD-friendly diet. There are some ground rule for this diet. There's a lot of diet in the world. Ground rule is this diet should have calorie restrictions to achieve weight loss. It can promote ketogenesis, and remember, some genetic predisposition of personal response to a specific diet is not very clearly understood. So personalized diet is important for patient to reverse MASH. So different guidelines, actually multiple guidelines, actually suggest Mediterranean diet is a recommendation for primary lifestyle intervention. So back to our case, Albert returns for routine follow-up with no improvement of labs. Remember, he has some elevation of LFTs. He admits that he has not begun any exercise regimen, but has been trying to cutting out soda. So how do we work with patients to create behavioral change? So we are a provider, we come out from one culture. We don't know too much about other culture, but luckily there's actually some validated assessment tool that we can ask when we see the patient as a baseline and when we see the patient back in 6 months, we can use the same questionnaire to screen if they improve in their diet and exercise adherence. And the scale is called EDAS, Exercise and Diet Adherence Scale. It is a voluntary questionnaire. While your MA is rooming him or her, you can have the patient fill in. There are 33 criteria checked to monitor daily exercise and calories intake. And this is a brief introduction to lifestyle modification. I hope you enjoy the content, and I'm open for any question.